Good afternoon, everyone. This month we are going to discuss how various testing procedures from SpectraCell laboratories actually correlates with the thyroid dysfunction and how several nutrients you'll see play a very important role when you are trying to deal with these individuals that have hyper and or hypothyroidism. One of the things you know that is very common with these individuals is they often tell you that they have normal thyroid dysfunction tests. However, when they come to your office, they have several complaints, whether it's dry skin, their hair is falling out, they have no energy, and so on. And so hopefully by the end of today and actually by the end of this month, when we go through the series for this particular testing, that you will see how a particular individual can come into your office, have normal standard testing, but how SpectraCell micronutrient testing and the other tests will correlate with what your next step should be for the treatment, and you will be able to customize, once again, your treatment. Hopefully you were with us last month when we talked about the micronutrient test and diabetes. Well, as I mentioned, this month is going to be thyroid. And once again, reviewing the procedure with the micronutrient test that SpectraCell uses the lymphocyte, the T lymphocyte, and this has been verified by several independent researchers that the lymphocyte is a very credible cell to look at for long-term nutritional evaluation. And as you all are aware, most of you were trained just like I was, that serum or plasma testing has been used in the past, and once again is a very static test. It only tells us in a very short period of time what's going on with that person from a nutritional status. As we all know, there are several things that affect us in regards to nutritional status, and here's a short list of the more common ones that affect our health and our nutritional status. And so when you are looking at these particular individuals, this is something that needs to be taken into account. And of course, some of these you won't know how it actually affects the patient by just doing a physical exam, and that's where you're going to have to do some laboratory diagnostics. For example, stress. I'll show you how stress can affect a person's nutritional status and how this nutritional status will also affect their thyroid function. We also know that some people can go for 4 to 6, maybe 7 hours of sleep, and that may be enough for them, and other people will require maybe 8 to 10 hours before they actually feel recovered. But one of the things that I think is very important, because a lot of patients say this to me, and they probably say the same thing to you, is, well, if I'm taking this medication for my thyroid, will I ever be able to get off of the medication? Most of the time, a person will have to stay on the medication, but the important thing about this is, can they decrease their dosage, or the dosage that they're taking, can it be leveled off where they always stay on that particular dose and it actually is beneficial to them? If you have a patient that is on a particular dosage of medication for your thyroid, and that person says, well, last month it was this dosage, 3 months before that it was another dosage, and 6 months before that it was another dosage, that usually is a strong indicator that the person has an abnormal nutritional status. And so at that point, this is where the testing will become very beneficial to the patient and also complements your therapy. Once again, if you are familiar with SpectraCell testing, this particular report on the front page of your M&T is a summation of what is going on with this patient in regards to functional deficiencies and borderline deficiencies. And it's very important, once again, to treat the functional or the borderline deficiencies just like the functional deficiencies. And my main objective with you today is to correlate how these particular deficiencies can coincide with thyroid dysfunction and how they can assist the medication and or possibly keep a person off of thyroid medication if their thyroid dysfunction is not real severe. So once again, that's something that the patient has to realize, that they may require thyroid medication, or if they're on thyroid medication, that it is going to be complementary of their nutritional therapy. As you know in your report, once again, if you're familiar with it, this is a listing of the different percentages or the numeric results of the individual. And of course, if they're borderline, it's going to be listed borderline in blue, and then if it's deficient, of course, it's going to be noted in red. And as I mentioned earlier, you want to address the borderline values just like the deficient values. It's very important for these individuals to, once again, know that you're going to try to combine certain things because certain nutrients are very complementary to one another. And on the other hand, and probably more important, is when you do supplement these individuals, that they realize that they need to be followed up, that giving therapeutic dosages of certain nutrients may cause imbalances or deficiencies in other nutrients. And this is a great example today on how certain nutrients that I'm going to talk about that are highly correlated with the thyroid are going to possibly become deficient when you give them a therapeutic dosage if you don't complement their synergistic nutrient. And once again, I'll get into that a little further down the webinar today. So in this particular individual, you can see this is a first page of graphs. And once again, if the person is in an adequate state, their squares are green. If they're in the borderline, the squares turn black. And if they are in the functional deficient status, they are, once again, the squares are red and they're in the blue. So blowing this up, taking the first particular row, and this, of course, involves the B complex vitamins, this is, you can see, a good indicator of an individual that is either under a lot of psychological stress and or physical stress. And when I say physical stress, meaning exercise. This is a typical pattern we see with individuals that exercise a lot or, once again, have a very stressful job. And when we see the B vitamins all hovering around the yellow or in the blue and the yellow, then once again we know that this is a situation where people are addressing a stressful situation. And that stressful state, once again, whether it's physical or psychological, is drawing them to utilize more of their B vitamins. And this is where, coming with the thyroid dysfunction, how it's going to come into play. And I'm going to show you a correlation with this. Now, two of the nutrients on this particular slide that are very important in regards to stress is the B12 and the panthenate. When those two are found borderline or deficient together, that is a strong indicator of stress. Now, this is a typical example where a person comes in and tells you that they're fatigued, they don't feel like exercising, their hair's falling out, their skin's dry, and they've already been to another doctor and they were told their thyroid function tests are normal. Well, once again, if they are having poor quality or poor status of the B vitamins like this, they could very easily be fatigued. They could very easily be suffering with dry skin, alopecia, and other signs and symptoms that are very common with thyroid dysfunction. So for that reason, this would be an early therapy to get them out of those signs and symptoms. But yet, they may not be at the full-blown state yet of hypothyroidism, or if they're, once again, taking medication because they do have hypothyroidism, are they taking too much medication, or on the other hand, are they hyperthyroid? So the point is that in either case, hypo or hypothyroidism, it's going to have a bearing on these particular B vitamins. The thing that we have to think about when we're looking at this is you can see here that if a person has a hyperthyroid state, that it's going to have a significant impact on some of the B vitamins. And you can see based on this particular slide that B6, the B5, the B1 are all indicated as being an increased need if a person has hyperthyroidism. On the other hand, if they have hypothyroidism and they're being over-medicated, it can cause a similar type of situation. And then you can see a secondary situation where if B6 deficiency continues, that the gastric secretion decreases as a result, then causes a secondary vitamin B12 absorption problem. So this is what I was talking about as far as synergistic nutrients. And this is why when people talk about fatigue, for example, since that's a common finding with hypothyroidism, is you can't just say, okay, I'm going to give this person a high dose of B12. I'm going to give them a B12 injection. Because even though they may feel good temporarily, it may be an underlying cause like B6 that is accentuating this particular deficiency of B12. And as we all know, all the B vitamins work synergistic with one another. They all have one or two that are more synergistic with one another. For example, B12 and folate have a strong synergism, where B2, B3, and B6 have a synergism in various ways. So the point is that we want to look at all of the B vitamins, not just one, and when we address the B vitamins, if we have one that's particularly low, we'll give a higher dose or a therapeutic dose of that, but we will still complement that one B vitamin with a B complex. And it may be through a B complex or maybe through a multivitamin mineral that helps supply the remaining B vitamins. Folate, you can see here, comes into play once again if we have a hyperthyroid state. And you can see here that this is very common. And once again, when we see people with thyroid dysfunction, one of the things that's documented is anemia. And there's different types of anemia that we've seen with thyroid dysfunction, whether it's hyper or hypothyroidism. We've seen the macrocytic hypochromic, we've seen the microcytic hypochromic, we've seen the normocytic normalchromic. When you look at a person from an anemic state, and we're going to talk later this month about a CBC and how it correlates with thyroid dysfunction, is when you look at that CBC is to determine is it macrocytic or microcytic or normocytic, and what nutrients are associated with that. I think the most common mistake that most doctors make is a person has a microcytic hypochromic, they give iron. A person has macrocytic and hypochromic, they give B12 or folate. And I think by the end of this month that you will see that there are several nutrients that can present the same way, and if you do that, you actually can mask a deficiency. For example, if someone is B6 deficient and it's causing a microcytic hypochromic anemia and you give them a lot of iron, you may correct the CBC, but underlying you haven't really corrected the true nutritional deficiency that may be present, whether it's B6 or iron or copper or something like that. So once again, this is where SpectraCell micronutrient test comes into play, and we'll show you that you customize their therapy based on this micronutrient testing. As I mentioned earlier, several people come into our office with common signs and symptoms of thyroid dysfunction, and yet when we do thyroid dysfunction tests, that they come back normal. And the analogy that I often use with my patients is it's kind of like your car that's out of alignment. Your tires are starting to wear, and if you don't do something about the alignment, they will continue to wear, and eventually you'll have to replace your tires. Well, the same thing is true with diabetes or thyroid or heart disease or osteoporosis or any of those conditions where they can continue to degenerate based on the nutritional status of an individual. So even though a person has thyroid dysfunction, or the thyroid dysfunction tests are normal, but they have something like alopecia or dry skin or constipation, there is a reason why they are suffering with those conditions, with those signs and symptoms. And you need to find that rather than just saying, oh, yeah, well, a lot of people have dry skin, or a lot of people are fatigued, or your fatigue is due to depression. And it may actually be due to nutritional deficiency that an individual has, and could be early warning signs of once again, thyroid dysfunction. Now, this is kind of a summation of a situation where a person has hyperthyroidism or, once again, has too much medication. And it's very important that we keep this in mind because some of these you will see later this month how I correlate some of these nutrients with autoimmune conditions such as Hashimoto's and why we need to address those so we can modulate the immune system and decrease the damage to the thyroid gland. Once again, you can see a lot of these are B vitamins, but there are also some fat-soluble nutrients and some metabolites that we're looking at that are very instrumental to other conditions. In fact, I saw a lady today who has thyroid dysfunction in my office, and she has a history of elevated cholesterol. And, of course, her question to me was, is there any correlation of elevated cholesterol and thyroid dysfunction? And, of course, the answer is yes. And so this is something that we want to keep in mind. And you can see, based on this particular presentation here, that since thyroid dysfunction is associated with cardiovascular disease, we have to keep in mind other nutrients that are associated with cardiovascular disease or stroke. And that would be like your riboflavin, your B6, your choline. Those are associated with homocysteine levels. And homocysteine, we know, is associated with cardiovascular disease and stroke. Of course, vitamin C is associated with elevated cholesterol. Choline has also been shown to be effective towards, once again, triglycerides, and something that we look at. And vitamin E as well for cardiovascular disease. So the point is that if a person is being over-medicated with thyroid, that it's going to cause some deficiencies that may give them signs and symptoms that actually kind of present like they're hypothyroid. And because several of these B vitamins, as you know, are associated with fatigue. The next row that we look at when we're looking at the micronutrient test on the first page is we look at what we call the amino acids and metabolites. And this is an interesting row, and for those of you, once again, that are new to SpectraCell, that you will notice that the amino acids on this particular row are all non-essential, meaning that the body can make them if we have adequate essential amino acids and adequate coenzymes or cofactors. The big point is adequate. Do we have enough of the essential amino acids through cofactor, coenzyme usage make the non-essentials? Now, I think this was very important to emphasize because when you look at this, a lot of people say, well, why did Dr. Shive go after the non-essentials and not the essentials? Because if you look at the essentials, it's strictly dietary intake. And if you look at the non-essentials like these, you can see that we, or Dr. Shive, wanted to know, can a person properly make these non-essentials from essentials? And that's, of course, if they had adequate protein intake. So this is where a lot of the B vitamins and some of the minerals that deal with cofactors and coenzymes will also be very synergistic in this aspect. Now, if you look at this, even though this particular nutrient is not in the borderline range or even the functional deficiency range, you can see that it's getting very close, and that's glutamine. And that's the second graph in. Where you really want to get these squares, at least where I want my patients to be, is mid-white. And so if you go a little further down that row and you look at carnitine, you see carnitine is in the middle of the white of its respective graph. That's really your goal, there or higher. Because if you do it at a level like that, then they have enough cushion to prevent a deficiency prior to the next test of approximately 5 to 6 months, or even if you did it in a year. But if you leave that level there of glutamine, and once again don't increase that, then in the next 3, 4, 5, 6 months, that person's glutamine level may drop into the yellow or into the blue and then be very symptomatic of various conditions, and also is associated with autoimmune disease because it's a role with the gastrointestinal tract. And we'll talk about that later this month when I correlate, once again, other findings with this particular disease. The choline, once again, you can see is in the blue, and so the square turned red. And then, of course, inositol. Inositol, we talked about this last month, where inositol had a role with insulin receptors. And we know that it has a role with hormone receptors. And even though there may not be a lot of information on inositol and thyroid dysfunction, I will correlate that later this month and how you should address it. But let me talk first about that choline, since it is deficient. If you go back and look at the B vitamins, you'll see that there are several B vitamins that were borderline. And of those B vitamins that are borderline, there, once again, are some of the B vitamins like B2, and B6, folate, and B12 that are in the methylation pathway that actually may give you some indication that this person is a poor methylator. And choline further substantiates it, because we know choline is in the methylation pathway. So as a result, when you see something like that from a micronutrient test, it may trigger you to order an MTHFR on the person in the future. And once again, especially if they're trying to, if a female is trying to get pregnant, because we know that thyroid dysfunction is associated with infertility. Well, we also know that abnormal methylation is associated with infertility. So if a person has been checked by their OB/GYN and their so-called thyroid function is normal, but she's having difficulty getting pregnant, this is where, based on the micronutrient test, may give you some heads up on, oh, I need to order an MTHFR to see if that's another reason why this woman is unable to get pregnant. So an accumulation of nutrients in that pathway, whether they're borderline deficient or deficient, will give you some reason to order additional tests like your micronutrient, like your MTHFR, along with the micronutrient test. Now, one of the things that often happens when I talk to clinicians about thyroid is iodine, iodine, iodine. We need to make sure that people are taking iodine. This is a good example, and you can see this research is back in the 80s and 90s, but I think it's very important that we realize that, because as I was telling some doctors this past weekend when I was lecturing to them, that just because this research is back in the 60s, 70s, 80s doesn't mean it's bad research. That it may be substantial research that we need to build on that other people need to investigate. And this type of research has been, once again, complemented in the past decade. So even though it was discovered back in the 80s and early 90s, that we have to bring this forward. As you can see here, on the very last bullet, it says 2- and 3-way nutrient interaction may have distinct manifestations in thyroid function. So in other words, we can't just set a person up on iodine and say, okay, I want you to consume a lot of iodine sources, or we'll give you an iodine supplement and you should be fine. Because you'll see here in a few minutes, and also later this month, how if you don't correct certain nutrients in addition to iodine, how that iodine is not going to be effective. And so it's very, very important. And we'll, once again, correlate the selenium and the zinc, and those two have a huge impact on our thyroid. And in fact, if there's only one nutrient that I would really go after with thyroid, or the first nutrient I'd go after, it would be zinc more than the iodine. And hopefully you'll see why that is in a few minutes. Now, there's been numerous pieces of literature saying what's the best way of really looking at zinc. Is it serum? Is it plasma? Is it urinary? There's been a lot of different controversy on that, but once again, if you go into literature in the past 2 decades, you will see that more and more people are saying that the red blood cell or the white blood cell are the best cells to look at in regards to nutritional status. The benefit of the white blood cell over the red blood cell is the white blood cell has a longer lifespan. And so you're looking back further. You're looking back 6 to 9 months, where the red blood cell, once again, is 3 to 4 months. The other main thing I want to emphasize about that is with SpectraCell, you're getting a look at several different nutrients, where some of these companies out there will offer you, say, red blood cell zinc, but they don't offer you any other nutrient that's complementary or could be affected by given zinc if zinc was found to be low. The other thing is that vitamin A has a very strong association with zinc. And so a lot of times when people have a vitamin A status that's low, people just throw vitamin A at them, instead of saying, well, let me go look at the zinc and see if the zinc is low, because if zinc's low, that may be the cause of the low vitamin A. And so keep that in mind, and once again, you'll see how vitamin A is affected by the thyroid hormone, and it's one of the reasons why that people that have thyroid dysfunction often have eye problems, is vitamin A status. But we also know that similar eye integrity is affected by zinc. So this is why whenever you are looking at someone that has, of course, night blindness or nyctalopia, that we look at vitamin A and we look at zinc status. And it's very important to realize that zinc has a high affinity or tendency for individuals that have a lot more musculature than an individual that has less musculature. So once again, males may require more zinc than females for several reasons, not just because of muscular integrity, but also the need for testosterone production. And so this is something that's very important to look at, is what ethnic background is a person involved with, because once again, we talked about that last month with diabetes, how Hispanic and African Americans have a higher tendency for diabetes. In this case, our gender may definitely help decide on what dosages we're going to give. If it's a female, we may give a lower dosage of zinc to correct their zinc deficiency, where if they're a male patient, we may have to give them a higher dosage. Now, here's some reasons why, or things that we see with zinc and thyroid function. We know, once again, that proteins cannot be synthesized in the body without the assistance of zinc. And so when we look at albumin, when we look at globulin, when we look at thyroglobulin, when we look at various other proteins, besides amino acids playing a role, we know there are other nutrients that play a role. And zinc is a major player. So whenever we're talking about protein synthesis, we want to think of zinc. You can see that zinc is involved with the T3 nuclear receptor. And so whenever a person is producing thyroid hormone or is taking a thyroid hormone prescription, that in order for that thyroid hormone to work properly, we have to have zinc because of its binding capability, the T3 binding to the nuclear receptor. So it's kind of like if a person doesn't have enough or a high enough sensitivity with their insulin receptors, they release more insulin. The case with the thyroid is if we don't have adequate zinc, if we aren't producing enough thyroid, a person's going to have hypothyroid-like tendency. And once again, if a person is taking medication and they have a zinc deficiency, that medication may not be working efficiently. And once again, as we correct the zinc, their medication works more efficiently. And then you can see here there is a study done by Watt and King that found that when zinc depletion was involved later with repletion, that TSH, the total T4, free T4 was affected, and once again, that these levels seem to return to normal when zinc was repleted. So once again, we have to think about this. Now, I'm going to divert a little bit to this because I think it's very important that when we talk about zinc, that we talk about the bioavailability of minerals or period of nutrients. zinc glycinate has a very high bioavailability, where forms like zinc gluconate and zinc citrate or zinc oxide have lower bioavailabilities. They're also more prone to being affected by various factors, which I'll talk about here in a little bit. But the point is that it's very important to realize that one zinc isn't the same as another. And even though you're looking at doses, so a person says, well, I have thyroid dysfunction, I went down to the store and I picked up the zinc and it didn't seem to affect me. Well, if they picked up something like zinc gluconate, because of its poor bioavailability, it may not work. And so they might have given up on nutritional intervention with their condition. In actuality, you give them a good quality product, then you will resolve that and their thyroid function may improve. Now, one of the things that we also have to take into consideration is certain nutritional products and how they may affect our hormones or medications and so on. And you can see here, this was published in a journal in 2005, showing that there might be some inhibition when carnitine is taken when we talk about thyroid hormone. And so for this reason, we have to be a little cautious on if a person is carnitine deficient, is if we give carnitine, is it going to affect the person's thyroid hormone that they produce and or the medication that they're taking. I always tell my patients that we have to take supplements at least 2 hours away from any medication, whether it's thyroid or anti-inflammatory, whatever. But in this case, we may have to give carnitine at the very latter part of the day if they're taking thyroid in the morning. So once again, when you're trying to address this particular deficiency, and as you know, this amino acid is very important for several things. It's important for beta oxidation. It can help prevent, of course, neuropathies. It's important for, once again, central nervous system function, muscle soreness. When people talk about muscle soreness, again, this is something that we have to look at. And when we're talking about carnitine, we always have to talk about pantothenic acid and CoQ10. And those other nutrients there that I just mentioned are synergistic in one aspect, but also antagonistic if we give a therapeutic dosage of any one of those. Now, vitamin C can help make carnitine. So if a patient is low on vitamin C, this is something that we could give them and see if they could manufacture carnitine. And it would be an indirect way, but possibly a negative feedback mechanism that once the body makes enough carnitine, it doesn't really interfere with thyroid dysfunction, whereas we give pure carnitine or acetyl-L-carnitine, are we going to cause thyroid dysfunction? So that's something that you're going to have to monitor, but realize that there is a correlation with this amino acid and thyroid. Now, once again, when we're talking about different functions of nutrients, this is an example of how zinc has an effect on cell structure. And as I mentioned earlier, it talks about protein synthesis and how it's a regulator of cell integrity. And this is one of the reasons why zinc should be looked at very strongly whenever you are dealing with protein synthesis or regulation. And if a protein, whether it's albumin, whether it's globulin, whether it's retinol-binding protein, should always be looked at so it can complement the protein intake. And this is possibly why when people consume a so-called adequate amount of protein, they don't get the benefit of it because they have some micronutrients that are lacking. So very, very important to keep in mind. Now, when we go to the next row of the micronutrient test of the first page, you can see that there's some fat-soluble nutrients and then there's minerals. And you can see in this particular case that there's really only two nutrients, calcium and copper, that are in really good status. That vitamin D, A, K2, manganese, zinc, and magnesium are all in what I would consider suboptimal levels. So we're going to have to address all those. And what's important about that, as I mentioned, we've talked about zinc and thyroid dysfunction, and so this correlates well with this particular case. Vitamin D, we're going to talk about that a little later today as well as this month in regards to the autoimmune presentation. And we've talked about this in the past, and you've seen this in the literature, that vitamin D, K2, and magnesium have a strong connection with one another. And of course, we all know that calcium, magnesium has a strong correlation, and zinc and copper have a strong correlation. So keeping that in mind, this is a good example of this person has a good calcium status, but a borderline deficient magnesium. We know that if we give magnesium, we have to give calcium. Now, this is where usually we talk about a 2-to-1 ratio of calcium and magnesium, but in this case, we might go a 1-to-1 ratio of calcium to magnesium because the person has a lower level of magnesium than you do calcium, or you could even maybe possibly go a 2-to-1 magnesium to calcium and see if that affected it. With the zinc and copper, you can see the zinc is borderline and the copper is adequate. So the question is, do I give copper to this individual? Yes, you have to give some copper, but optimally we usually talk about a 10-to-1 ratio of zinc to copper. In this case, we might give a 15-to-1. I usually do not go above 15-to-1 because when we start pushing 20-to-1 zinc to copper, it's very common that the person's copper starts to significantly drop. And in this case, they can drop a little bit because they do have an adequate level, but you don't want them to continue to drop at a fast rate before you retest them. But it's something you want to watch for. Now, as I mentioned earlier, that we showed you where this person had a borderline zinc level. And we talked about zinc and how it comes into play with protein synthesis. What's really important, as I mentioned, is the nuclear receptor. And it's something that I'll talk about later this month on how we see sometimes an elevated T3 with a person has a normal T4, and it correlates with a zinc deficiency. So it's very important when we're looking at these particular individuals that we keep in mind these micronutrients and we keep in mind the balance of the micronutrients. Otherwise, once again, we will push them from one enzyme or coenzyme that may be borderline or deficient to another that may become deficient and involve another enzyme that could be very crucial to the person's health. Now, we talked a little bit about quality, and I mentioned about zinc gluconate and citrate and oxide and so on. The thing that's really important to realize is our divalent cation, of course, zinc being one of them, is highly affected by things in our food called phytates and oxalates. And why is this important? Because we know that if a person has a high intake of phytates and oxalates, that they may be taking a zinc in a salt form and may actually be decreasing the absorption. You can also see here in the third bullet where calcium, once again, may increase the inhibitory effect of phytate on zinc absorption. So mineral to mineral may have an effect as well as a product like phytate or oxalate on zinc and or calcium. So this is where a person said, but no, you don't understand. I'm consuming a lot of foods high in zinc or consuming a lot of foods high in calcium. Well, if they're consuming a lot of foods high in calcium or zinc, but they're also consuming a lot of foods that are high in phytates and oxalates, they may not be adequate in regards to absorption, and this is why they come up poor on the test, because they don't realize these interactions, and of course that's why you're there. Now we talked about this earlier where thyroid has a relationship with various other findings, and one of the things that we know is that thyroid has a relationship with cardiovascular disease, and if we have a low thyroid, that once again a person may have, or I should say hypothyroid, they may have an elevated cholesterol and or triglycerides. On the other hand, if we have hyperthyroidism, we may see the opposite. So if you're doing a cardiovascular panel and the person has a significant low cholesterol, a significant low triglyceride, and you haven't done a thyroid function test yet, it may indicate to you that you might have to do that. So once again, you can rule out hyperthyroidism. And because once again we know that cholesterol is very important for certain function of the body, one of them, of course, being vitamin D synthesis, and it has, of course, other relationships with hormones as well. So we always sometimes think about elevated cholesterol and elevated triglycerides as being detrimental, but a lower cholesterol and lower triglyceride may, once again, give us some indication that a person has excess thyroid medication and or hyperthyroidism. You can see here that, once again, hyperthyroidism can affect the minerals, and you can see that talks about calcium levels being affected, and once again, magnesium as well being affected. Now, there's one thing we always talk about, and even though the micronutrient test does not look at this, but we look at magnesium, but we don't look at potassium, is where magnesium goes, often potassium follows, because as you know, they're primarily intracellular nutrients. So if a person has a low magnesium on the micronutrient test, they may also have a low potassium, even though, once again, the micronutrient test does not look for potassium levels. So it's something to keep in mind because it's a nutrient that you could complement them with, give them foods high in potassium to make sure that potassium and magnesium are in balance. Now, as I mentioned, zinc often is talked about with hypothyroidism because of the thyroid receptor. Well, you can see here that we see a high serum zinc value have been reported with elevated or hyperthyroidism. So the point is this, is when we're looking at serum, is it really the test that we want to be looking at because it's a static test? Well, if you look at the bullet below that, it'll say that there's studies that show that red blood cell zinc concentrations are decreased in thyrotoxic patients and increased in hypothyroid patients, showing that we are changing the level or compartments of zinc when we have hypo or hyper. And once again, if you went off the serum, you would see that the serum levels of zinc are elevated with hyperthyroidism, thinking or making you think that the person has more than enough or possibly toxic in zinc, when in essence it's really a compartmentalized change with these particular nutrients based on hyper or hypothyroidism. Now, as I mentioned, whenever you talk about zinc, you have to talk about vitamin A. And whenever you talk about zinc, you always have to talk about protein. And there's a couple proteins here, prealbumin and retinol-binding protein, that are highly associated with zinc. And the point is that prealbumin is a protein in our body, which a lot of people don't use, but they should, as far as in diagnostics, because it has a very short half-life. And when you are trying to determine whether or not you are giving a person adequate protein, this is the protein you want to look at. If you are used to monitoring albumins and globulins, they have, especially albumin, has a very long half-life. Some people say 18 to 21 days. And so it would take at least 18 to 21 days to determine if your protein intake was adequate for that patient. Where with prealbumin, you could know that in 48 to 72 hours. The retinol-binding protein is a protein we look at when we are associating vitamin A, because vitamin A attaches to retinol-binding protein and is carried to the areas of need. And once again, this is one of the reasons why zinc and vitamin A are synergistic with one another. Copper, once again, people talk about zinc and thyroid, and if you, once again, do something with zinc, you should always monitor copper. And this is very important because you can see here that copper is associated with certain enzymes, and there's a product, of course, that's copper associated with, and it's called ceruloplasmin. And we have seen these values change, once again, based on thyroid function. As I showed you in the earlier MNT, I showed you where this person had a zinc that was borderline, and their copper was very good. So if you just address the zinc and you didn't address the copper to some degree, you could actually affect it. Now, one of the things that's really important about copper is copper helps maintain iron status in the body. And you will see later this month how iron is instrumental for thyroid function and how iron deficiency presents a lot like hypothyroidism. So when you're thinking about iron, you also want to think about copper because of the synergistic effect. And copper deficiency on a CBC can present just like a iron deficiency. So by looking just at a CBC with differential, it doesn't really tell you what nutrient to go after. It just gives you a finding telling you you need to address all the nutrients that affect hemoglobin or red blood cell production or the indices. Manganese, not talked about much with this particular condition, but once again you can see that they've seen a correlation with red blood cell manganese concentrations in T4 and T3 levels. They do, once again, recommend that manganese is monitored. Manganese is very important, where you can see for superoxide dismutase, which is a powerful antioxidant. So when we do look at Spectrox on SpectraCell, we have to consider manganese as a nutrient that affects Spectrox, but also manganese is very important for connective tissue. So if you're a clinician and you deal a lot with osteoporosis, osteopenia, osteoarthritis, stress fractures, various things like that, you want to definitely take that into consideration. So this is the second page of the micronutrient test, and we're going to break this out one by one and show you how certain nutrients that we talked about will affect, once again, thyroid. So the first box you can see on the second page is carbohydrate metabolism box, and this is a box, of course, talks about fructose sensitivity and how a person actually metabolizes fructose. So this can be affected by too much fructose. It can be affected by other nutrients that help metabolize fructose. And once again, when fructose sensitivity is abnormal, it can elevate triglycerides, it can elevate uric acid levels, and eventually it can cause insulin resistance. Now the glucose-insulin interaction, once again, is associated with insulin resistance. And one of the nutrients that has a big impact on that is chromium. And we talked about this last month when we talked about diabetes. The reason why I want to mention this is because when people talk about fatigue, which is common, as you know, with hypothyroidism, that one of the causes of fatigue, as you know, is hypoglycemia. And as a result, this is something to help confirm or rule out if that's an issue. Now, the chromium is borderline deficient, where the glucose insulin is okay. It could be better, of course. I like it usually up around 55 on my patients. But the point is, do we leave this chromium alone or do we address it? And I say address it now because, once again, it can cause fatigue if it's abnormal and cause somewhat of a reactive hypoglycemic presentation and eventually type 2 diabetes. And also is associated with elevated cholesterol. So when a thyroid patient has elevated cholesterol, is the elevated cholesterol actually due to hypothyroidism, or is it due to a combination of hypothyroidism and chromium? Now this is a row of antioxidants, and when you see Spectrox, Spectrox is affected by this row, but it's not only affected by this row. And that's one of the things I want to emphasize because we want to look at all these nutrients. So any nutrient that has antioxidant capabilities can, once again, affect the Spectrox. So when you are looking at the Spectrox, you want to think of antioxidant quality products. It may be a nutrient that has an indirect effect on another antioxidant. For example, vitamin B2 riboflavin. Riboflavin itself is not an antioxidant. But riboflavin works with cysteine to make glutathione. And as a result, riboflavin has to be considered when we see an abnormal Spectrox. So indirectly, riboflavin has a role. And that's something that's very important to look at. And that's why this particular marker on SpectraCell is very difficult to maintain in the white because so many nutrients affect the Spectrox. And once again, that previous slide where I showed you that row of individual antioxidants are the major ones that people look at, but are not the only ones that we look at. The immunodex, once again, this is really the first 5 days of growth of the cells. It used to be called the LPI, the lymphocyte proliferation index, and now it's called the immunodex. And so people do correlate this somewhat with the immune system. And so the same thing is true with the micronutrient test. As far as the nutrients on that test, if any nutrient on the micronutrient test that has immunological function will affect the immunodex or can affect the immunodex. A general statement about this product or this finding is any nutrient that affects cell membrane integrity may definitely affect this. And that's why it's very important to look at is, does this person have something that is going on, whether it's something like cancer or some strong inflammatory condition like rheumatoid arthritis or lupus or any condition like that, any autoimmune diseases, or are they taking some medications that may be causing some damage to the cell membrane? So all of this has to be looked at when we are looking at the immunodex. The selenium, which of course is one of the amino acids that we look at, is a nutrient that all of you are familiar with, and we know that this particular mineral is responsible for the conversion of T4 to T3. So whenever you see a patient that has adequate T4 on a thyroid dysfunction panel and they have a low T3, instead of possibly giving them T3, what you might want to consider is give them selenium if you've done this test and selenium is low, and let selenium take T4 and convert it to T3. And you can see these are the enzymes, there's 3 of them, that we looked at in regards to selenium's relationship and correlation with. So this is how selenium plays a huge role with the thyroid gland. And once again, it would also have an effect on the SpectraCell and also have an effect on the immunodex. They've shown when selenium and zinc are deficient alone or in combination that there's definitely been change and alteration of the thyroid gland. And this is something, once again, that's very important. As you can see, a lot of people today talk about the inflammatory process and how it causes numerous pathologies. And this is another example, and you can see on the top bullet where the thyroid glands of these deficient selenium animals showed definitely an inflammatory reaction going on and eventually a fibrotic type process occurring and would cause damage to the thyroid gland. As I mentioned, there's a lot of synergistic nutrients. We talked about zinc and copper. We talked about calcium, magnesium. We talked about vitamin D, vitamin K, and magnesium. These are 2 that are extremely synergistic in regards to the thyroid, the zinc and selenium. And then we talked about iodine earlier. And this is why when people are trying to promote iodine as a treatment for thyroid, you always have to, once again, consider zinc and selenium with it. And you'll see later this month when I continue this series on SpectraCell testing and thyroid function, how iron comes into play with these other nutrients and how it is a large part of thyroid function and why we have to look at iron status with the thyroid individual. So I'm going to open it up for any questions you may have at this time. Try to address it. If not, I highly encourage you to continue with this series the rest of this month where I correlate various testing, the cardiometabolic, the CBC, once again, the comprehensive metabolic profile with thyroid dysfunction and the micronutrient test, and how you will see that this is really looking at nutrients to get at the root of the problem or this particular pathology, whether it's hyper or hypothyroidism, but definitely the normal function, and how a lot of those deficiencies of the nutrients we talked about today can cause the typical things of alopecia, dry skin, elevated cholesterol, and how you can't just give someone a nutrient or product like omega-3 fatty acids for elevated cholesterol when it might be an underlying thyroid dysfunction, but yet not showing up significantly in thyroid function tests, but some nutrients like zinc and selenium that have a large role with thyroid are showing deficient, and that's really what's causing the elevated cholesterol. So I thank you for your time and look forward to talking about further testing with thyroid function this month. Once again, have a great day and look forward to next week. Thank you.